Can hear me now, is that right? Great. Well, thank you, Mary Grace, for inviting me to talk today. It's also nice to see some familiar faces, and looking forward to speaking with you over the next hour, and I'll leave time for questions at the end as well. So Mary Grace has asked me to talk about giving a general overview about Alzheimer's disease, and specifically younger onset Alzheimer's disease. Sorry. Sorry. Here we go. So in terms of when we think about the progression of Alzheimer's disease over time, I think you guys can see my pointer here. Is that correct? So this is over many, many years. We see that there is a gradual decline in cognitive functioning. And as this decline happens, there are different terms that we use in terms of the different stages. And so that's superimposed on the gradual decline that's happening. And so at first there are changes that are happening below the surface, and nobody can detect any sort of symptoms such as any changes in thinking. Then there is what we call a prodromal stage. So a beginning stage when the person who is experiencing the symptoms, or those around them, or both, start wondering, is there something going on? And if they were to undergo an evaluation at that point, there would be some subtle signs that would be picked up on cognitive testing. And then as time goes on, gradually we get to a point where it's more and more difficult for the person to do the things that they used to do on their own. And that's when we use this term dementia. This prodromal stage, though, when there are some concerns about changes, and yet the person remains independent in everything that they continue to do, has a special name. And this is called mild cognitive impairment, or MCI. And more it's being recognized that this is an important stage at which potentially to be diagnosed, because it's thought that this is a good point to try to jump in and think about making sure we have a correct diagnosis, and then also about treatment. And what is really hard is, the scale here. We are talking about years. We're not talking about a dramatic change over weeks or months. But for each person, the amount of time it takes to progress through these years is not clear. And it depends on many different things. It probably depends on the person's own brain from the beginning, but also many different life experiences. But this is also the hopeful part of it, in that there are ways that we can intervene so that the time it takes to experience this decline over time is extended. So when we think about what sort of changes happen over time, so in the mild cognitive impairment stage, examples of what a person might be experiencing are, they're double and triple checking things, like making sure, is there an appointment tomorrow? When is the appointment? Where's the appointment? Instead of just looking at the calendar the night before, there's multiple checking throughout the day. Making sure that the grocery list, again, you might be able to before typically remember 6 items without a list, but now really need to bring a list with you and cross off every item as you get it. Again, double checking those bill payments, but all of these things, with all of that checking and these compensatory strategies, in the end, the person is able to do all these things on their own. It's just requiring a bit more effort to get it done. And so there can be this period of time where people who don't know the person as well, or don't see them as often, might not notice any changes. And so sometimes that can be reassuring. Sometimes that can also be frustrating if you have a diagnosis of MCI and feel like there's other people dismiss your concerns. Then we get to the stage of dementia, which is a term that has a lot of stigma, unfortunately, and also, unfortunately, carries, it applies to a wide range of years. So this range is from mild stage dementia all the way to severe stage. There are many different staging systems. There's seven stages, all different stages, but this is a bit simplified into mild, moderate, and severe stage. So if we think about mild stage dementia, this is at a point when the person experiencing symptoms needs help from other people to accomplish things they used to do on their own. And usually it's just a little bit of help in the beginning. So the person may need some reminders for appointments. Rechecking the calendar themselves isn't enough. May need reminders from other people about taking medications occasionally. There are things that used to be effortless, just taking a quick trip to the grocery store. Now it takes more time, and there may be some frustration that goes along with it. There may also be frustration if somebody is providing reminders about things that used to be effortless. And driving concerns may start to arise as well. So getting to unfamiliar areas may be more difficult. And there may be a few more dings on the car, harder to get the car in and out of tight spaces, harder to navigate intersections. By the time we get to moderate stage dementia, this is when a person needs help for what we call more basic activities of daily living. So changing clothes, remembering to wear different clothes for the night and then get a new change of clothes for the next day. Putting an entire meal together, might need help with that. At this point, disruption of a routine may turn out to be very stressful. And so, again, there may be some emotional component there, and it may be overwhelming to put up with crowds or do things that are not part of the typical routine. There may also be some confusion at night. So waking up in the middle of the night, not realizing it's 3 a.m. and getting ready for the day. When we get to severe stage dementia, this is really towards the end, and this is when somebody would need hands-on help with basic tasks such as bathing, eating, and going to the bathroom. And at that point, communication can be quite difficult as well. Again, these are examples of what may happen over time, and the journey for each person is unique. So many of you have been through this process, but in case there are friends or family members that perhaps didn't start this journey with you, I just wanted to give an overview of how somebody gets a diagnosis of cognitive change, either MCI or dementia due to Alzheimer's disease. So when the person comes into the doctor, either because of their own concerns or the concerns of someone who knows them well, the physician hears about what's been going on. What are the concerns about changes, and what has been going on day to day? What is different because of these cognitive changes? And it's always really helpful to hear both from the person who may be concerned about themselves and from at least one person who knows them very well. And so has a sense of, is this something that fits in with changes they've always had or not? Then there's an examination, often checking various things such as balance and coordination, doing some cognitive testing. And often we have to make sure that there's nothing else going on that could either be the cause of these cognitive changes or contributing to it. So it's always important to go through all medications, and that includes anything that's over the counter. Going through other causes of thinking changes, such as how sleep is, whether there is a risk of having any seizures causing these symptoms, or perhaps an undiagnosed or untreated psychiatric disorder. Also, sometimes blood tests are performed to make sure there's not another medical condition, such as thyroid disease or diabetes, that again could be causing or contributing to the cognitive changes. And then one thing that is rare, but we do want to make sure is not the cause of the cognitive changes, is whether there could be a brain tumor pressing on, for example, the memory center of the brain, and then causing these symptoms. So in order to look further for these different causes, again, I mentioned there may be some blood tests that are performed. Typically, there is a brain scan that is performed, and it's a structural brain scan to look for whether there may or may not be a brain tumor, or also, for example, whether there could have been a stroke that caused these symptoms. And so that's usually a CAT scan, a CT scan, or a brain MRI. And then sometimes there may be further tests performed, and especially if somebody is very young to be having these symptoms, this is when the further testing is often pursued. So that may include neuropsychological testing, so that is several hours of testing to really get an understanding of all different types of thinking. So visual memory, verbal memory, attention, visual spatial abilities. Then in terms of the brain scans, as I mentioned, often there's a structural scan. An MRI can give a lot of detail about the brain. And then sometimes a functional brain scan, such as a PET scan, is performed. And again, that's usually done at a subspecialty center. And if there are questions about whether this could be Alzheimer's, again, often this is pursued when somebody is younger than we would expect to be developing these symptoms. And then sometimes a lumbar puncture or a spinal tap is performed. And this is in part to rule out other causes of thinking changes, such as whether there might be an infection in the brain. Again, that's usually less likely because the symptoms would come on much more rapidly typically than in Alzheimer's disease. But we can also test the cerebrospinal fluid for the protein profile of Alzheimer's disease. So that is why sometimes a spinal tap or a lumbar puncture is performed as part of the evaluation for whether Alzheimer's disease is causing the thinking changes. But the other thing that's really important is that the person that you see to get the diagnosis should also continue to follow you over time. Because if we're thinking about a diagnosis of Alzheimer's disease, as I mentioned at the beginning, this is a disease that, unfortunately, at this point, we do expect to continue to progress over time. So part of being more confident about the diagnosis is getting to know someone over time and seeing whether the changes that we predict do indeed happen. And this sometimes involves repeated cognitive testing to see if there is the predicted change. But not all the time do we repeat the tests. A lot of it is hearing how the story changes over time or not. So I mentioned that brain scans are performed. And so on the left side here, this is a structural scan called an MRI. And the view that we're looking at is looking at the person head on. And so it's like we're slicing the brain as if you were placing a tiara on the person's head. And so what we see here is just as important as what we don't see. So we do not see a brain tumor. We also do not see any major strokes. So those things do not account for this person's thinking changes. What we do see is right here is a structure of the brain called the hippocampus, a memory center of the brain, and it is actually smaller than we would expect for that person's age. And so that helps us think that the changes that we see on the brain scan are likely due to Alzheimer's disease, and thus this person's cognitive symptoms are likely due to Alzheimer's disease. On the right side of the screen is an image of a PET scan. As I mentioned, this is more of a subspecialty test, and it's not typically ordered as part of a routine evaluation for Alzheimer's disease. But we do sometimes think about getting a functional brain scan, such as a PET scan. And this is actually a side view. So as if we slice the person's head in right down the middle, and we're looking from the side. So here's the front of the head and the back of the head. And when we look at a PET scan, we're looking at a pattern of metabolism. So that's why it's called a functional brain scan. And we're looking to see if there are areas in the brain that have low metabolic activity, and if those areas are in areas that we expect to be affected by Alzheimer's disease. So there are many areas in this brain where the metabolism is normal and healthy, but as we track back, there is an area of signal dropout. And this is an area of the brain that is fairly specific for having low metabolism in Alzheimer's disease. So this is partly how we start to understand the causes of the cause of the person's thinking changes. So once we make a diagnosis of cognitive change due to Alzheimer's disease, then we start thinking about, well, what can we do about this? And even though at this point in time, we do not have medications which can stop or reverse the changes that are happening in the brain, there are lots of things that we can do. So this is only a partial list, but just again to give you a bit of an overview of what we think about, how we think about intervening at different stages. When somebody is diagnosed with mild cognitive impairment due to Alzheimer's disease, there is actually no medication currently that is FDA approved for MCI due to Alzheimer's disease. And so instead, this is really the stage where it is so important to put these brain healthy habits in place. And the thought is that these brain healthy habits will help carry you through the remainder of the journey. So some of these brain healthy habits include having a good calendar system. So having a very regimented system for where appointments are kept and having this organized and being able to refer to it in a very easy way and having other people know where to refer to it. Starting to use a MediSet for medications, so taking medications from a weekly pill box as opposed to taking them right from the bottle, so that you can always go back and check, did I take my medications today or not? Making sure that you're getting regular sleep and exercise, and also thinking about a good mix of social and cognitive activities. So keeping your body engaged and your brain engaged. And what do you find fulfilling? And again, getting into these good, healthy habits so that, for example, with the exercise, if you miss a session of exercise, you miss it. This is not something that becomes optional, but it's part of a good, healthy routine, because the routine can also be very reassuring to the brain. As we go on to mild stage dementia, that is when we think about starting some medications to help the memory system. And so typically a medication we start with is in the class of what's called a cholinesterase inhibitor. And these are examples of the different types of cholinesterase inhibitors. You would only be prescribed one of them, and some of them all of them are available in pill forms. There's different administration, whether it's once or twice a day. And one of them, the rivastigmine, is also available as a patch in case, for example, sometimes people get bad stomach upset, and sometimes the patch may be easier for that. But usually, by the time somebody has mild stage dementia, they would be prescribed a cholinesterase inhibitor. When we get to moderate stage dementia, that is when we think about adding to the cholinesterase inhibitor a medication which is from a class called NMDA receptor antagonist. And so this medicine is called memantine or Namenda, and that is in addition to the cholinesterase inhibitor which was previously prescribed. By the time we get to severe stage dementia, and especially if it might be very difficult for the person to be taking things by mouth, that is a point where sometimes there is a consideration of tapering off medications. But it really should be done with the guidance of a physician, and the medicines should be tapered off as opposed to stopped suddenly, because At that point, the brain may be very used to those medicines, and an abrupt cessation of the medications could cause some worsening confusion. But at all stages, one thing that we do want to pay attention to is whether there are symptoms of depression or anxiety, because being depressed, being anxious it causes more difficulty with thinking, and it would be important to make sure that this is not what's being experienced. And sometimes these symptoms can be relieved with these memory medicines. Sometimes they require additional medications. And often it also requires paying attention to the scenarios which may prompt these feelings, and readjusting the environment to reduce the depression and anxiety. So it's not just medications. There's lots of environmental and behavioral interventions, and some of these you'll be hearing about later today. Throughout this, though, we also want to make sure that we pay attention to what strengths are maintained through much of this time. So while short-term memory may be affected, long-term memory remains intact for a very, very long time. And so it can be wonderful to think back on good memories, to talk about this. This person can share their experiences from a long time ago. Looking back on picture books, these are important things to keep coming back to. Similarly, there is a different type of memory system called procedural memory. You might think about this as sort of muscle memory. So this is the memory system you tap into, for example, when you ride a bike or go swimming. These are the procedures that your brain is able to kick into and carry out without actively or effortfully pulling up all of the individual steps. And because of this strength, that is again why we like to emphasize getting into those brain healthy habits early. Because the sooner you get into those habits, the sooner they can be put into procedural memory. So for example, if you get into that habit of putting appointments on a calendar, then that can gradually go into muscle memory, and you find yourself referring to the calendar almost automatically. So again, we like to focus on what strengths there are and what will carry us through with compensatory strategies. Emotional experience also remains a strength and can be quite powerful, and being in the moment and experiencing those emotions. And sometimes the memory, the emotional memory and experience brings back, that can be intact for a very long time. And then there can be the emergence of creativity and imagination. I love this painting here. It looks kind of like a red meanie from the Beatles' Yellow Submarine is, and so people can become, can discover new strengths in art, or have blossoming artists. This is from the Art of Alzheimer's, a local organization. And that also can be a great way to engage the brain and keep the brain active. So considering not just strengths to fall back on from your past, but also what are new areas that you can explore. So when we think specifically about younger onset Alzheimer's disease, what the terminology right now refers to symptoms beginning before 65 years old. That may change over time. I think more and more as hopefully we decrease the stigma of this diagnosis and people become more aware of changes that happen that may be due to Alzheimer's disease, it may be that many more people begin to recognize symptoms before the age of 65. But certainly if the symptoms begin when somebody is in their 50s or even younger, this is when we think about a diagnosis of younger onset Alzheimer's disease. And what can be tricky is that a person's symptoms may not be of the classic short-term memory loss. This can happen in older onset Alzheimer's disease, but it seems to be more common in people who have younger onset Alzheimer's disease, that The symptoms may actually be language changes or behavioral changes or other changes such as visual spatial difficulties. So it's not always short-term memory loss in the beginning. There can be also other complications as the disease progresses. So this includes that there may be higher rates of seizures and a type of twitching called myoclonus. Overall, though, there is always a concern that perhaps these changes are happening because of a gene mutation, and that maybe this gene mutation can be passed on to the next generation. But it actually is usually not the case that there is a specific gene mutation that has caused young onset Alzheimer's disease. It remains unclear why some people develop these symptoms many years before others. But again, it's quite rare to have a specific gene change causing the Alzheimer's disease. But there are special considerations for young onset Alzheimer's disease. As some of you or many of you may have experienced, it can be a much longer journey to get to this diagnosis. Simply in part because having Alzheimer's disease is not often on the radar for somebody in their 50s. It's not part of the screening for somebody in the routine medical screening for somebody in their 50s, for example. And unfortunately, sometimes the symptoms are dismissed. Somebody going through menopause may simply be told, oh, that's menopause. That's why you're forgetting. Everybody else has these symptoms too. So it can be a very frustrating time to have to see many different physicians before reaching a diagnosis. Someone may still be working, and there is a breakout session later today to think about special considerations in the workplace. Also at home, someone may be in sort of the sandwich generation, caring for their own children at home, potentially caring for parents. So being a caregiver and not used to being on the receiving end of caring. Support groups, with a good fit, can be harder to find because many of the support groups for people with Alzheimer's disease are for those who are much older, decades older, and again, dealing with different issues. And then towards the end of the journey, the options for a higher level of care may be limited, unfortunately, by age. Just to come back to when we're thinking about this progression over time, Alzheimer's disease is a specific type of brain disease. And so as we see this change over time from, these are the clinical symptoms of, we don't see any change initially, then mild cognitive impairment, then dementia. Underneath it all, in the brain, there is this gradual accumulation of what we call neuropathology. And that is how we get the specific diagnosis of Alzheimer's disease. So if we were to look at brain tissue under a microscope, what we see are these two types of abnormal protein accumulations. So one are the tau tangles, and those are these accumulations of hyperphosphorylated tau within the brain cells. And then there are the plaques. These are different from cholesterol plaques. These are amyloid plaques, which are forming around the brain cells. And these can be seen when a piece of brain tissue is looked at under a microscope with special stains. And gradually, as these plaques and tangles accumulate, they build up and cause the cells to malfunction, and gradually the cells can accommodate for a certain period of time, but then it gets to a point where they can no longer compensate and the cells begin to die off. And so that is when we can see the shrinkage in certain areas on the brain scan. So when we think about where can we make headway in treating Alzheimer's disease, the areas where there are targets for research are, one is just to understand what is going on. This is where you may have heard the term about biomarkers. How can we get better at diagnosing someone if we know that there are changes in neuropathology going on even before somebody has symptoms? Are there ways that we can measure that or detect that before the person develops cognitive change? Are there protective factors or risk factors, for example, with somebody's lifestyle, with the genetics? Even if there's not a deterministic gene change, there may be risk or protective gene factors. And then finally, ultimately, there continues to be a search for what we call disease-modifying treatment. So a way to reduce that burden of neuropathology. And the hope will be that if there is less accumulation of the amyloid plaques and the tau tangles, that then there would not be as much damage to the brain tissue, and so the cognitive symptoms would not progress too much over time. So in terms of what might be on the horizon, there is a lot of work being done to see if there is a blood test which could help us with a diagnosis of Alzheimer's disease. And so that is coming along and may be present in the near future. Another way to think about diagnosis is to get a different type of PET scan, and this would be an amyloid PET scan. So the dye, which is injected, actually clings onto briefly the amyloid in the brain. So this is a horizontal section through the brain. This is a healthy brain without any of that amyloid plaque. And here you can see that there's, this is a brain that has amyloid plaque in it. And you can see the uptake of the dye. And these PET scans actually have been FDA approved. They are available, but unfortunately, insurance at the moment will not cover it. So there is actually there are studies going on to try to demonstrate first to Medicare that making a diagnosis of cognitive change due to Alzheimer's disease is meaningful and will change the course of treatment. And the reason why Medicare is being targeted is because if Medicare approves coverage of a test, then usually all other insurance will follow suit. And so there has been a first round of a Medicare research study, and there's actually a second round happening now or about to launch, which will include people with potentially younger onset Alzheimer's disease. And I do want to clarify that in the clinic, this PET scan would only be available to people who are experiencing symptoms that are concerning for Alzheimer's disease. It would not be used in the clinic right now if somebody has no symptoms at all. And then also still in the research realm is the development of tau PET scans. So it's amyloid and tau together that is the cause of, is the basis of Alzheimer's disease. And so this is looking at the pathologic staging, and it seems like if we can detect the tau change over time, that can actually help us get a sense of how the disease is progressing and then potentially also response to treatment. Other research that is going on, this is just one example of many. And this is a study that's going on right now at the University of Washington, and they're actively recruiting people. This is for people with mild cognitive impairment, and it's called Memory Improvement Through Nicotine Dosing, so MIND. And it's actually using a nicotine patch to see if that could improve cognition, because nicotine stimulates those acetylcholine receptors. So that first medicine that is started works in the acetylcholine system. And the thought is that maybe a nicotine patch could help boost acetylcholine. So this is one option for treating the symptoms of Alzheimer's disease in an ongoing interventional trial. But there are lots and lots of targets for intervention in Alzheimer's disease. Again, this is where we can be hopeful, but this is also probably why there will be no single silver bullet for treating Alzheimer's. Similar to where cancer research has led us, where now there's a lot of characterization of different types of cancer, potentially genetic underpinnings, consideration, for example, of surgery, chemotherapy before or after surgery, types of chemotherapy. Likely that is what will be needed in Alzheimer's disease too. So there's going to be lots of different ways to target the protein accumulations themselves, and also the impact of the protein accumulation and at different stages of the disease. So there is lots of different research going on, and if you were to be interested, different ways to participate as well. There was a few years ago, the Lancet, which is one of the premier medical journals, put out a study on how can we prevent, intervene, and care for people with Alzheimer's. And again, you can see there's lots of different ways to go about doing this, and these are interventions that can likely help at all different stages. So having, using your brain in ways that are challenging, having a good education seems to be very protective for the brain. Making sure that other diseases which can affect brain health, so heart health, vascular health, diabetes, stopping smoking, all of these things have a very important impact on the brain. There is thought about brain inflammation. Specific trials haven't been able to really find, again, a specific inflammatory cure, but that continues to be an area of intervention. And then you see in the middle here, exercise can help all of this. But there's many, many different ways to make a difference in brain health. So just in closing, if any of you are interested in learning more about research opportunities, there is a research coordinator at the University of Washington Alzheimer's Disease Research Center, and her contact information is here, Teresa Keene. The Alzheimer's Association also has a trial match program. I would be cautious about making sure you screen the source of where you're getting the information from, and always feel free to speak with your own physician about whether a trial is a good match for you. So this is why there are these specific recommendations of where to get information about research participation. Clinicaltrials.gov is from the government and can be a good resource, but sometimes it's a little clunky to navigate. And then this last website is a good way to keep up to date about all the latest research findings and debates. So it doesn't mean you have to participate in research, it's more just to learn what are the latest thoughts. And with that, there's a little bit of time for questions.